Welcome, everybody, colleagues, panelists, lecturers, and attendees. Tonight, we're going to start one of our new webinars in the Mega Learning. We have two important lectures today. Let's start first with Professor John Doyle. Professor John Doyle, he is a professor of anesthesiology in Cleveland Clinic, Case Western Reserve University, USA, and he's going to give us today a lecture about an update in drug safety and anesthesiology. Dr. John, can you start, please?
Thank you, everybody, for the opportunity to present on a topic that is very important, and that is drug safety. A good place to start in the discussion of drug safety goes back to the 1950s with a drug called thalidomide. This was a drug marketed to the public in 1957 as a wonder drug for insomnia, for colds, coughs, and headaches, and it became licensed in the UK and elsewhere. In 1961, several years later, William McBride, an Australian doctor, noticed that there was an increased number of deformed babies at his hospital, all to mothers who had taken thalidomide. And thereby the connection was made that thalidomide would cause damage to unborn babies. And the drug was withdrawn in November of that year. Here's the phocomelia that we see as a result of the thalidomide. And there was a whole cohort of children born that required special care as a consequence of this, all from the drug thalidomide. In 1962, the Food and Drug Administration Inspector Francis Kelsey received an award from President John F. Kennedy for blocking the sale of thalidomide in the United States. And this was one of the great triumphs of the United States Food and Drug Administration, in that they did not approve the drug when it was applied, and they saved many, many thousands of babies from phocomelia. Let's consider some of the other horror stories that you may have encountered in your clinical experience. Here's one where 3 mLs or 30 milligrams of rocuronium instead of 3 milligrams of rocuronium were given as a defasciculating dose to an awake patient. We don't do defasciculation as much as was done in the past, in part because we don't use succinylcholine that much anymore. But you can see that this immediately required that the patient be put off to sleep as soon as it was recognized that they'd given the wrong drug. Another drug error that I noticed in my clinical career, this happened in our post-anesthetic care unit many years ago. Instead of 3 units of insulin to treat hyperglycemia, 300 units or 3 mLs were given. In this case, the error was recognized more or less instantly, and serial glucometer measurements plus serial boluses of glucose ended up with the result that the patient was not harmed in the least. In another story, 200 milligrams of morphine were given in a post-anesthetic care unit or recovery room by virtue of a pump runaway, PCA being patient-controlled analgesia, due to a hardware failure. So basically, the pump kept giving more drug than it should have, resulting, of course, in a respiratory arrest that, in this case, was recognized and treated. Here's another story, this from the Institute for Safe Medical Practices. On the left, you can see a bag of heparin, and on the right, a bag of hetastarch. And in this particular story, instead of giving the 6% hetastarch, the patient received 25,000 units of heparin in this bag. And of course, the anticoagulation had to be treated. Here's another story, this one from Canada. Fatal outcome after inadvertent injection of epinephrine intended for topical use. And it's worthwhile taking a look at this. Here's the incident. During a day surgery ENT procedure, the surgeon requested local anesthesia for injection, lidocaine 1% with epinephrine 1 in 100,000. And this is universal, it's used around the world. He was handed a pre-drawn syringe and he injected medication into the surgical site. Immediately afterward, the patient experienced cardiac arrhythmia, leading to cardiac arrest, and despite full resuscitation measures, the patient died. So here is ampule or vial of epinephrine, 30 ml in 30 milligrams and 30 mLs, and it's for topical application only. In this case, it got injected because of a medication error. Another sad tragedy, the epidural injection of 15 mLs of 15% potassium chloride, when the potassium chloride was mistaken for distilled water and used as a diluent for bupivacaine. The patient's physiological reaction was immediate and severe, resulting in permanent paraplegia and then death 6 months later. Another story relates to this movie star, Dennis Quaid. A medical mistake nearly killed his twin infants and put him on a personal crusade relating to the reduction of drug errors. So 3 infants at one of the most reputable hospitals in California received 1,000 times more heparin than intended when vials containing 10,000 units per ml instead of 10 units per ml were used in error to flush the infant's vascular access lines. No doubt the intense media attention given to these errors is related to the fact that 2 of the infants were the newborn twins of Hollywood celebrities, Dennis and Kimberly Quaid. And so that affected them quite a bit, and they went on a mission to try and improve drug safety. Pharmacy technicians accidentally placed vials containing the more concentrated heparin, 10,000 units per ml, in storage locations in patient care areas designed for less concentrated heparin, and that would be 10 units per ml. Vials containing the different strengths of heparin actually look similar. So the nurses, who were accustomed to finding only the 10 units per ml concentration of heparin, did not notice the error until after the wrong concentration had been used to flush the infant's access lines. So on the left, you can see the heparin at 10 units per hour, and immediately to the right of that, you can see the heparin in darker blue at 10,000 units per ml. And of course, it was the second of these that was given instead of the 10 units per ml and resulted in complications for the patient. So this resulted in Dennis Quaid wanting to initiate a program to prevent drug errors. And so this was in the news quite a bit. And it also led to a lot of people being interested in this problem of drug errors. And one of the places most interested in this was the Institute of Medicine, that issued a report called Preventing Medication Errors. The reference is down below, and it was published in 2007. They estimated that 1.5 million preventable adverse drug reactions occur annually in the United States, and of course, more around the world. Another study estimated that 530,000 preventable adverse drug events occur each year among outpatient Medicare benefits, Medicare being the system for universal health care for the elderly and the infirm. The annual cost of treating preventable adverse drug reactions in the Medicare system for enrollees age 65 and older is estimated at $887 million based on available data at the time. So this came from the Institute of Medicine, and instituted a lot of interest in the problem of initiating programs to reduce drug errors. Take a look at this prescription. Does anybody have a guess what it actually says? This is a real world order that came by. And if you look at it carefully, you might be able to see that this is for morphine 10 milligrams IM. It is problems like this that have led to a lot of hospitals using electronic ordering. And in the hospital I operate on, it turns out that all our orders are electronic or verbal, but I haven't done a written order in memory now. It must have been at least 5 or 10 years. One of the things about writing orders by hand is that there are some potential errors that can occur because of dangerous abbreviation symbols and dose designations. This is from the Institute for Safe Medication Practices in Canada. And here are some of the error-prone abbreviations I bring to your mind. Abbreviation of U for unit is not a good idea because it's sometimes mistaken for 0. So alternative is write out unit in longhand. IU is sometimes mistaken for IV, so write international units in longhand. QD, mistaken for QID, so write daily instead. And similarly for QOD, you should write every other day. Similarly, you want to avoid trailing zeros after a drug. You don't want to say 5.0 milligrams because they may not see the decimal point and expect to give 50 milligrams as an example. So these are all things that are recommended to reduce the likelihood in error in orders that are written by hand. Here's another interesting study called the July effect. The study identifies a spike in fatal medication errors when new residents arrive, which in the United States is typically every July. And in this study published in the Journal of General Internal Medicine, fatal medication errors spiked as much as 10% in July inside medical institutions in the US counties that contain teaching hospitals. And this spike is informally known as the July effect or the new resident hypothesis. So the idea here is that medication errors are more likely with individuals who are just new to a particular system. So 3 themes emerged during the course of this study. Fatal medication errors spiked in July and in no other month. The July spike appeared only in counties containing teaching hospitals, but not in regular hospitals that don't have residents. And in these counties, July mortality from medication errors was 10% above the expected level. So that's a training issue, of course, and many hospitals are taking that into account. Another challenge is drugs that sound alike. For example, morphine and hydromorphone are similar enough that they account for about 3.5% of wrong drug errors. In this case, some 295 reports came through to regulatory authorities. Other ones is oxycodone and OxyContin, 2.2%, and clonazepam and clonidine, 0.6%, and so on. So a lot of these sound the same, and that can be a problem, particularly when giving verbal orders. So it's suggested in some cases that when a prescription is written, particularly in family practice, that one include a drug's indication on the prescription as a safety measure. So you can just check off what the appropriate clinical condition is. So if it's unclear whether a prescription says Celebrex or Serapix, a checkbox in the musculoskeletal box would suggest that it's Celebrex as the desired drug. Of course, in electronic prescriptions where it's all typed and checked electronically, this is less of a problem. Another challenge is lookalike drugs. And on the top, you can see 2 drugs that look very much alike. On the right, you can see a number of ophthalmic solutions that look the same. And on the bottom left, you have morphine 2 milligrams per ml on the top and morphine 4 milligrams per ml on the bottom, and they look very similar as well. Hydromorphone 1 milligram per ml on the top, and on the right, hydromorphone 2 milligrams per ml on the bottom. And these are obvious sources of confusion that regulatory authorities have to deal with. Here's a case example. There's Novolog 7030 and Novolin 7030, and they're not the same product. So you can see it's very easy to make a mistake like that. Here is a polyamp ampule containing bupivacaine, but they're labeled with the company's brand name, Sensorcaine, rather than the generic name bupivacaine. So one of the things that I'll get into later is the importance that all drugs have labeled with them at least their generic name. And here that has not been followed. Another error here, the pharmacy placed an isoprel or isoproterenol ampule in the low pressure ampules section of the cardiac support floor stock. The isoprel was removed from the stock and administered to a patient. Both products have the same blue stripe on the ampule and look rather similar. Another thing that is sometimes confusing is the dosage concentration. Here it's suggested that it's 1 in 5,000 rather than indicating the drug in milligrams directly. Now, there are a number of potential errors in drug delivery that will interest you. It's repeatedly said over thousands of years that to err is part of being human. And here, for example, from a text in 1635, I presume you're mortal and may err. Pope's essay on criticism, to err is human, to forgive divine. Sanders, who is an authority on human error, writes, to err is human, to forgive is against company policy. going on to comment that taking into account the nature of human error is very important in human factors activities. So here is John Senders commenting again. All of the above quotations that we saw earlier state that errors will be made by people despite their determination to avoid them. Yet people are consistently held accountable for their errors when they lead to accidents with adverse outcomes. Is this proper? I argue that it is not, in the same way that in law, no one is held accountable for acts of God. So this is Senders' position on this, and it is characteristic of a new way of thinking about human error that takes a look at the system rather than the individual. So one of the things that industry has been concerned about for quite some time is human errors in industrial accidents. And now a lot of that information has been used to understand human error in hospitals. So General Electric, Motorola, others have all reported complex programs that resulted in a marked reduction in the frequency of worker injuries. And the question is, can we do the same for hospitals? In the field of medicine, however, with the outstanding exception of anesthesiology, there's a paucity of information. Many reports referring to a 1984 Harvard-New York State study. And the scarcity of information, according to this source, indicates the complexity of the problem. But fortunately, because of an interest in this, there's been a renewal of interest on this very topic. It seems very unlikely that simple exhortation or additional regulations will help, because the problem lies principally in the multiple human-machine interfaces that constitute modern medical care. It's not simply a matter of offering more penalties. Concurrent with the studies of industrial and nuclear accidents, cognitive psychologists have intensively studied how the brain stores and retrieves information, and several concepts relevant to this have emerged. First, errors are not a character defect to be treated by the classical approach of discipline, education, shaming, but are products of normal thinking that occur frequently. Second, major accidents are rarely caused by a single error. Instead, they're often a combination of chronic system errors termed latent errors. And identifying and correcting these latent errors should be the principal focus for creative planning rather than searching for an individual culprit and blaming everything on them. In this regard, it's helpful to understand the difference between slips and mistakes. And this comes from research from Reason and Devon. Slips are errors in execution, and mistakes are errors in planning and action. And we'll have some examples. When is an action a slip or a mistake? Consider this scenario. Pressing the red rather than the blue button leads to an unwanted consequence. So if the correct intention was to press the blue button, then the action was a slip. If the intention was to press the red button, then the action was a mistake. So what kind of comments can we make about human error in medicine in general? Here are some classifications that can be helpful. In the case of a diagnostic process, failure to employ indicated tests, misleading or misunderstanding lab results, failure to act on the results of monitoring or testing. Example being potassium study showing 6.7 serum potassium. You want to urgently act on that rather than simply file it away. Treatment errors can occur, errors in the preparation of the treatment like dosage, and we saw examples of that earlier. Delayed treatment or inappropriate care, another classification. The failure to provide prophylactic treatment or preventive errors that can occur, inadequate follow-up of treatment as an example, or inadequate monitoring during anesthesia. And then other examples are available: failure to communicate, particularly in the chart, equipment failure, situated environments, especially the operating room and ICU, where there are special considerations, especially for ill patients, and a lot of technology. Here is a cartoon. The doctor says, "It seems we had a mix-up with your test results." And Dilbert on the left says, "Then I'm not dying?" The doctor says, "We doctors are amazingly smart, but occasionally we make a little error." And Dilbert says, "Well, I understand." And then the doctor goes on, "By the way, your pap smear was normal." Now, Swain and Gutman has come up with some human error categories that can be applicable not only to medicine, but to general life. An error omission, for example, might be a typographical error, as I've shown here. An error of commission might be hitting your thumb with a hammer when building something at home. An extraneous act would be, for example, reading the wrong report. A sequential error might be lighting a fire before opening the damper if you have a fireplace. And a timing error might be running a red light when you're driving your car. So these are all examples of human error categories, and they can be applied to medical situations as well. An error of omission, forgetting to give a muscle relaxant before intubation. Error of commission, giving a beta blocker to a bradycardic patient. An extraneous act, drawing up drugs not needed. Sequential error, giving drugs before checking your equipment. And a timing error, giving succinylcholine to an awake patient. Examples of drug-related errors in this particular classification. So let's take a look at drugs in the workspace and how the workspace might be better organized for this particular set of goals. One of the things we can do is improve drug and syringe labeling. And it turns out that the International Organization for Standardization, the ISO, has come up with a variety of recommendations, and there are others, as indicated in the references below. Another challenge is sleep deprivation, particularly among residents. In response to concerns about patient safety as a consequence of resident sleep deprivation from overwork, in 2003, the ACGME, which handles graduate training for medical residents and interns, they enacted rules which limit resident duty hours to a maximum of 80 hours per week and set other restrictions, such as a 24-hour limit on continuous duty time with an additional added period up to 6 hours for transfer of care and educational activities. And so these restrictions hopefully made it easier to have residents carry out their training and operate efficiently. The ACGME rules also require a minimum 10-hour rest period between duty periods so they can get some sleep, and require programs to give residents at least one full day off from patient care responsibilities every week. After all, they have to go and buy groceries and that kind of thing, and they need a day off for that. These regulations are based on well-supported concerns that sleep loss affects cognitive and clinical performance and possibly, in fact, likely, patient care. One starting point for many of these changes was a famous American case out of New York called the Libby Zion case. In 1984, Libby Zion was an 18-year-old college student admitted to New York Hospital, suffering from fever and agitation. The junior resident caring for him made a diagnosis of viral syndrome with hysterical symptoms during his 22nd hour of work. When Libby Zion thrashed violently throughout the night, the exhausted resident ordered meperidine or Demerol, a drug that is contraindicated for patients receiving MAO inhibitors, which Libby Zion was taking. And the next morning she was dead. You may also know meperidine as pethidine. And not many people are getting MAO inhibitors anymore, but remember this was 1984, and the SSRIs and the other drugs often used for the treatment of depression were not then available. Believing that hospital negligence had killed his daughter, Sidney Zion, a newspaper columnist, a lawyer, well-connected New Yorker, sued, charging that clinical experience and resident fatigue were responsible. Residency training in New York State was substantially altered as a result, with duty hour limitations and augmented supervision as a result, and increased the number of residents as well. For those interested in more information on human error in medicine, there is a couple of articles here, and there are many more recent ones as well. These are some of the ones that were leading the movement some 30 years ago. An important aspect to drug delivery is medical ergonomics, or medical human factors. I'd like to comment on that a little bit. Drug delivery ergonomics is concerned with the safe and efficient delivery of drugs from the supplier all the way to the consumer. So for suppliers, it deals with drug distribution, warehousing, storing the drugs, putting them in medical offices and cabinets and so on. For consumers, we're concerned with patients, with hospitals, clinic, medical offices, narcotics cabinet, and so on. We want to make sure that the arrangements of ergonomics are appropriately done. And so I can offer you here 10 drug ergonomic principles that can be useful to reduce the likelihood of drug error. And these are shown here, and I'd like to go through them all with you. First of all, principle number one, the labeling should be clear, unambiguous, sufficiently large fonts, and good print contrast. Secondly, special warnings or instructions should be highlighted and prominently displayed on the packaging. For example, maybe sedating, avoid heavy machinery, shake well before use. And another example of that I would offer is that on vancomycin, when you give that, it would be helpful if there were a drug label right on the package saying, do not deliver as a bolus to be delivered over 1 hour for vancomycin as an example. What about product identifiability? The products such as tablets should have a unique marking to allow patient recognition. All products should have a product code, a lot number, an expiry date, and a comment on the route of administration. Thirdly, the generic name of the drug should be prominently displayed on the drug label, and I gave you an example of that earlier. Secondly, the drug brand name, if displayed, should not be expected to result in the drug being misidentified with another drug or with a generic drug. Next, for tablets and other oral dosage forms, the dose of each tablet should be clearly stated, but not necessarily as tablet markings. Tablets should be marked with a unique identifier. Labels for drugs in liquid form should clearly indicate the concentration and volume. Next, the strength of the product should have predominance over the number of units in the package. Next, the drug packaging should not present a safety hazard to users. And this is where glass ampules that totally disintegrate when opened can be a problem. And I've seen many anesthesiologists with cut fingers as a result of that. And finally, we want to address special needs that can occur. Patients with limited vision, patients with arthritis, child-proof containers. These are all special issues that have to be dealt with, particularly when providing prescriptions for outpatients. Additional suggestions: label adhesive should be colorless. Barcodes, if used, should not interfere with label legibility. There should be a high level of contrast between the print and the background. Don't use transparent glass as the print background. What about some violations of sound drug principles? Hard to read drug ampule labels, unlabeled syringes, difficult to find generic names, confusing brand names. These are all things that we want to deal with. And then there are a number of challenges that we need to deal with in the future that I'd like to bring to your attention. We need to disseminate information, such as I've done, about the ergonomic principles of drug delivery, support research into further understanding of drug errors, have an internet accessible anonymous reporting system for drug errors with links to other interest groups, and elimination of confusing brand names. That brings an end to the discussion, and I hope you enjoyed this presentation. And I certainly hope that you're able to bring on the message about drug safety to all your friends and colleagues, and particularly those people you are training. Thank you again for your time.
Thank you very much, Professor Doyle, for the lecture. I myself enjoyed it very much, and going through the lecture, I couldn't agree more, calling it like horror stories. We have all been in, like, holding an ampoule in our hand and then reading the name to find it a very different drug than what we intended to give. And many of us are guilty of the horror stories, especially when we're trying to write medicines at the end of the shift. It's usually a bad handwriting. We have one question from Dr. Mohammed Sulaiman. He is asking, some ampules are labeled with very small writing that is difficult to read, especially with COVID drug from abroad companies with unfamiliar design added the problem. Stressful environment during the COVID period increased the risk of drug errors. Do you have a comment on this situation?
Yes, it's an unfortunate situation, and to deal with it, it's necessary to contact the appropriate regulatory authorities and send them a letter, for example, or send them a phone call or an SMS letting them know that this is a problem, particularly if you're able to photograph the ampule or vial in question. That can bring it to their attention. There are discussion forums where you can do this, but contacting the regulatory authorities is the first step for a process. And that doesn't result in immediate changes. The other thing you can do, of course, is contact your own pharmacy department and ask them to add additional information onto the ampules and vials by way of a tag. And this is sometimes done with additional information when this is needed. It's just a matter of attaching a tag onto the ampule or vial with some adhesive.
One more question from Dr. Mohammed Sulaiman again. Do you suggest the use of one language, for example, English, irrespective of the nationality of the producing companies?
That's a very hot political question, and so I really couldn't give a good answer. Number one, while that may work in the United States, it almost certainly would not work in China, where in many regions of China, Cantonese or Mandarin are the only languages spoken, and English would not be something that could be useful. Even in China, the question is, well, if you had to pick one language, would it be Mandarin or Cantonese? So it's a complex question, and I certainly don't know the answer for it.
Thank you very much, Professor Doyle, for the lecture. I don't think we have. No, there's one more question popping from Ahmed Khattab. He's asking, should we apply obligatory QR or barcodes on each ampoule with electronic reading instruments?
That is an excellent suggestion, and you don't even need electronic reading instruments. You just need your iPhone or your other smartphone, and it will read it automatically. So I suggest barcodes, QR codes, not just on drug ampules with a little paper attachment, but also on the anesthesia machine, where you can immediately get additional information about, for example, how to do your machine check. Or if you have a blood warmer, a little QR code on that showing how to particularly assemble it. It's so easy to do. It really is.
Yes. Thank you very much, Professor Doyle, for the important, interesting lecture, for your time. No more questions up to the moment. If anything pops, we'll ask you later in the session.